you all so much for having me. I appreciate it. I think it's important for me to start by just acknowledging you all and acknowledging a couple things about myself that it's hard for me to have a conversation about something like this without first starting with acknowledging my privilege. Gender. I'm a first-generation American. My family's from North Africa. My father was a physician. I grew up in a home of medicine where it was fairly easy for me to find a path forward into medicine. And so I start with that acknowledgement just because the topics that we're going to talk about today are fairly deep and intense. But I'm going to try to, and I didn't realize I had a 2-hour lecture, so I put together a series of slides that I think really kind of will take us through the story of structural racism in healthcare and the things that we can do to eliminate structural racism in healthcare. I'm part of the South Central AETC, and I'm the medical director for the Access Health South Central AETC. But as the AETC, I can only talk about certain things. I can acknowledge and point out structural racism in healthcare, but we can't really talk about things that you can do as a result of structural racism in healthcare. So we started the Center for Health Equities, and the Center for Health Equities gives us the opportunity outside of the federal mandates of the AETC to allow me to, and to allow our folks and our team to talk about what we can do as a result of our structural, racism in medicine. These are I'm on the advisory board for several pharmaceuticals, talking about HIV. I am an HIV doctor, and so you were going to hear things with respect to HIV and structural racism in the setting of HIV, and structural racism in the setting of hepatitis C. Yes?
Your lasser's not working. Could you speak up louder so it's not working?
Really? It's not working?
No.
It's popping. Yeah, do you want to use them? We're gonna get it switched out. Dr. Dery, do you want to use them? Yeah. We're gonna get it switched out. Wait, you want to use the mic, the handheld mic? Yeah. Just for now.
Check. All right. You don't need me to start over again, do you guys? All right. All right, so let's talk about America, health, and inequity. So in April of 2017, The Lancet, which is a British journal, released 5 excellent articles. Has anybody seen or read them? Or Lancet, British journal, April 2017. Amazing set of 5 articles that were all under the category of America, health, and inequity. There's no way that a U.S. medical journal would have done what The Lancet did. And so this is kind of a summary of those articles and that data. I start with this picture to remind myself, this is me getting married. I'm 50 years old. I just got married a year and a half ago. I've never been married before. I don't have children. Thank you. Thank you. I thought I was going to be a bachelor forever, but they say that when you meet somebody, you'll know. I met Liana, and there we go. I start with this slide because it was an interesting slide. So this is me 17 seconds into my ceremony, and I got bored. King ADD right here. So I took out a picture, and I just shocked everybody. And then this is my very close friend, Evan, who was our photographer, who took that picture. And then, yes, that phone case is a picture of me and my wife. So that is a... So the reason why I start with this picture is that if you flash forward 8 years before that picture was taken was the first time I started giving lectures about social determinants of health and structural racism in medicine. And the first lecture I gave was at a national conference for pharmacists. And in retrospect, probably not the best place to start talking about this sort of stuff, but there wasn't a name for social determinants at that time. And in fact, the idea and the data, basically they wanted me to talk about new HIV medications, which is why I was hired to do it, but I asked them if I could talk about some new interesting kind of social constructs of the etiology of HIV, especially in southern Louisiana where I live? And they said, sure. And as I started talking about it, people got up and walked out on me. And the reason why I have this picture of Leon and myself is because that was our second date. I don't think we'd call it a date, but in retrospect, it kind of was. She just said, hey, can I come see you give a lecture? And kind of turned into a lunch, and then it turned into me being horribly embarrassed because people got up and walked out. And if you ask her, she'll talk to you about that day, she'll be like, it was nothing. Nobody walked out on him. She's being very, very polite. And I was very embarrassed by that. But I stuck to my guns because I think it was very important. And somebody needs to be talking about this because it's not talked about enough in healthcare. So flash forward a couple years later, a journalist from Eon magazine, which is an online magazine, came down and followed me for 3 days. And she was the first one that kind of helped me document some of these things that we were talking about. Again, social determinants still didn't really quite have a name at this point. And then everything kind of changed about 2 years ago when Time magazine came down and did a 4-page spread on what I have been doing with my then Tulane clinic. Now I've moved out of Tulane after about 15 years and now at an FQHC called Access Health. And the reason why I did that was for more flexibility to do and talk about some of the things that I talk about now. It was a little bit more difficult to do so in kind of the setting that I was in. But the reason why this was important is that this really kind of helped legitimize a lot of the stuff that I've been talking about. Not that I think it needed to be legitimized by a journalist in Time magazine, but it was really helpful, right? It was very, very helpful. And so I've been kind of aggressively moving forward since then. So let's get started. So when we talk about poverty and we talk about infectious diseases, you're going to hear me say this over and over again, that infectious diseases are diseases of the poor, right? That's, if you're going into infectious diseases, you are going into infectious diseases as a physician, at least, or clinician. When I say physician, I am meaning to encompass all clinical entities of clinical medicine. But when you're going into infectious diseases as a specialty, you're really going in to advocate, be an advocate for the poor. And that's just the way it is. And a couple things that I say is, if you look at the top 3 killers in the world, the top 3 killers in the world are HIV, malaria, TB. And they're not happening in Sweden, right? Right? They're happening in Southeast Asia, in Russia. They're happening in all through Africa, through South and Central America, right? Places that we traditionally consider to be places that are poor. So, infectious diseases are diseases of the poor, all right? And so, when you think about, of course, poverty now and poverty in the United States, and I'm going to be making this point here pretty aggressively, if I can get this thing to work. When we talk about the South and why the South is plagued by poverty, we'll talk about that in a second. Hint, it goes down to Jim Crow laws. But when you look at Louisiana, we have some of the highest rates of HIV. We have the highest rates of poverty, and simultaneously look at where the Jim Crow laws actually were in effect. Mostly took effect in the South. What are Jim Crow laws? I think Michelle Alexander in her book, The New Jim Crow, does a far, 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 far better job than I can right now. But essentially, in short, these were laws after the Civil War that were enacted that helped codify and institutionalize racism within the law. That's essentially what Jim Crow laws are. And an example of a Jim Crow law that most people will remember is Miss Rosa Parks, who's one of my personal idols. Was in the days in the South, the buses were segregated, of course, where African Americans sat in the back, and of course, non-African Americans or Caucasian or white people sat in the front. So that's an example of Jim Crow law. It's an example that most people here, as I look around these faces, were probably alive at that time, or close to being alive. I was born in '68, so I was close to being alive. And certainly what we're seeing now is, and I think what we feel now are these remnants of these Jim Crow laws. But there is a Jim Crow law that we have in Louisiana. that we now have the opportunity to potentially combat, which is this election, we actually have the opportunity to go to the ballot and change the state constitution. The state constitution in Louisiana says that is as a result of this, which is our mission was in the first place to establish the supremacy of the white race in this state to the extent to which it could be legally and constitutionally done. So this was a constitutional convention that occurred in 1898. And what that did was it codified into law something called a non-unanimous jury. The idea of a non-unanimous jury is this, is that in every other state except for Oregon, anybody here from Oregon? All right, people from Oregon don't like when I say this, but Oregon was actually started by white supremacists. Who knew? I did, because this is what I do. Oregon and Louisiana are the only two states in the Union that can convict somebody with a jury trial with 10 jurors, not 12. And if you look at the last 6 years in the state of Louisiana, there were 402 people who went to jail on non-unanimous as a result of 10 people voting yes and 2 people voting no. So those 402 people would not be in jail right now as a result of this law of a non-unanimous jury. No one else does it in the country. The state that was founded by white supremacists and the state that openly admitted that they were instituting a white supremacy are the two states that allow for non-unanimous juries. Anybody from Louisiana? All right, this election cycle, we have an opportunity to change the Constitution. What effect do you think that had on the state's incarceration issue? It put us #1 in the world for incarceration. Louisiana, now there's some rumblings that Oklahoma may have taken over that dubious distinction, right? But right now, Louisiana, and not even Louisiana, New Orleans in particular, has the highest density of people incarcerated per capita of people that live in the Orleans parish. And so we have the highest number of people in jail living in Louisiana. And so this right here, I could stop and be like, all right, lecture done. This is the definition of structural racism right here. Period, end of discussion, right? I could literally just walk away and be done, but I've got another hour and 45 minutes to fill, and I will fill it, I can assure you. So let's talk about infectious diseases. Of course, this is very similar to the previous map. Infectious diseases are diseases of the poor. And when we look at Jim Crow states, the same overlay, and then now look at where you see the highest rates of mortality, right? Also in the South, and I think these are just infectious diseases. And when you just start looking just straight up at infectious diseases, you're seeing, if it's possible for me to get a pointer, my pointer's not working. The infectious diseases are mostly in the South, and mostly in my state of Louisiana. All right. Then, again, superimposing the issue of poverty. Then when you're looking at mortality for HIV and AIDS, of course, we see a large part of it also in the South, from Texas onward all the way to the east into Florida. So again, these are the same states that have the highest rates of poverty, and these are the same states that are affected and are still affected to this day by the institutionalized racism in the process of these laws that we refer to collectively as Jim Crow laws. So this is a study that just recently came out, actually came out a couple weeks ago, looking at physicians. And so the study was primarily looking at physicians, and it was the physician survey, comes out every couple years, and they were looking at burnout by physicians as well. There's more physicians that are leaving and retiring sooner. Thank you so much. Oh, that's pretty cool. I keep one in my bag, but for some reason this one's not working. Physicians are retiring now younger than ever before. And some and ID physicians are retiring as well. Lots of infectious disease doctors. In fact, there was a point when we were talking about infectious disease doctors earlier, I meant to tell you, do you know that infectious diseases as a specialty is going unfilled 50% every year? There was a point I was trying to make, and I couldn't remember what it was. 50% of the seats are going unfilled every year for infectious diseases specialty. So as a specialty, it's slowly declining. Because again, I think the type of work and that people just when they became a doctor, they didn't want to sign up for a lifelong of dealing with social determinants of health. And in this slide here, they're saying that 90% of physicians that were surveyed have had patients who are affected by social determinants of health. And when physicians are surveyed, they are surveyed as to why they are leaving the profession. It's because they feel as though the social determinants of health for the patients are getting more than they are able to handle. We know how to deal with diabetes. We know how to deal with Hep C. God, Hep C is probably the best example to give, right? $80,000 for treatments? Really? Right? I mean, when you look at, do you know what the treatments are in France? They're like $5,000 for the Hep C. I mean, it's completely ridiculous. And this is the country that we live. You guys don't mind me talking like this? I have I talk very free. I have my own radio station called WHIV, and I tend to sometimes talk like this, and I forget sometimes the audiences that I'm in. So, but this is the country that we live in, basically. We know what, as physicians, as healthcare workers, as you guys were here and talking about the work that you all are doing, I couldn't help but think to myself, if we were in a different system of healthcare, we wouldn't be exerting so much energy to these very basic things. It almost feels like we're constantly pushing a stone uphill, or like the Red Queen in Alice in Wonderland, who was always running just to keep in place. And that's what it feels like. And this stood out to me, that 90% of physicians that were surveyed, were affected by the social determinants of health. And that's how profound our system has become. I am being... what's that? Oh, there we go. Thank you. Got it. I am not... Oh, it did work, right? I will just keep both of them in, and I'll use one for advancing, and I'll use one for... All right, so this is a slide that's basically looking at, this is called the, Jesus. This is a slide basically looking at inequities and financial inequities, and using the Gini coefficient to look at financial inequities. And what we're essentially seeing here is the highest levels of financial inequities that happened in the 20s and the 30s, and of course after that came the Great Depression. And then after that, we had about 4 or 5 decades of financial equity, right, in which people referred to as the good old days. Right? Those were when, and of course, when we say that, I also am taking into consideration, of course, not everybody in the United States thought of that as the good old days. But particularly, the reason why was there was high levels of unions. There was 40, 50, 60% levels of unions. There was a strong middle class, and industry was in the U.S., and these runaway CEO and executive pays were not quite in place as they are now. And then you could see somewhere in the 80s that completely took off. Of course, that corresponds with Reagan and Reaganomics. In 2007, you see a dip where the Great Recession happened, and then, of course, then you see the continuing of this. This is going to crash. This is going to crash, all right? And it's going to be very painful, and it's going to be very painful for a lot of people, all right? So that is not if. This is a definitive when. So we just need to be very cognizant of that. And we need to look back at history and let history be able to teach us a bit about what's coming forward. These are a series of slides that were put together looking at the U.S. and at the Organization of Economic Cooperation and Development. And what you see here is that the U.S. has the highest rates of one-year-old death rates. We have the highest rates of child mortality over time. And this is in comparison to all the other countries, right? These other so-called industrialized countries. We have the highest rates of infant mortality than any of the other so-called rich or resourceful countries. We also have the highest rates of adolescent death rates as well. And we're tied with New Zealand. I was shocked when I saw that. I don't know how New Zealand showed up there, but it did. But still, compared to the other 19 countries that are in these OECD countries, or these OECD collective, we have the highest. Now, why is that? Well, it's largely because our healthcare system is one that's based on profits, as opposed to being based on people, right? The rest of the world pays on average about $5,000 a year per person for their health care. We pay $10,000 per person to start, and then we're delayed every step of the way. It doesn't take into consideration co-pays, doesn't take into consideration your medications, okay? And not only that, all these other 19 countries, their healthcare dollars compared to GDP is usually anywhere between 5 to 8%. Ours is almost close to 20%. So we're paying a disproportionate amount of money for healthcare, and we're getting worse outcomes. And the reason why is that the majority of the money that we're paying doesn't go into the administration of healthcare. It goes to profits, because that's the country we live in. So when we talk about social determinants, this is an example of social determinants. So if you just look at something like smoking, right? Who's adversely affected by smoking? Everybody knows smoking is bad for your health. I remember being very young and walking into a room when I was very little, when I was 5, and my dad is European, North African. Most people say that's it's like South Europe, but my dad is of European or North African descent, so is my mother. Everybody's smoking in the house. I walked in, I started coughing, and I remember coughing. I remember this very vividly, and I remember not wanting to be in a room where people smoke because it made me cough, and I didn't like to cough. It hurt when I coughed, right? Now, either I was profoundly intuitive, or somehow I, knew that I was going to grow up to become a doctor, and I had the mind of a doctor, or I just recognized smoking was bad, right? My dad actually saw that, and my mom and dad quit smoking on the spot when they saw me coughing, and they saw that I was really having a response to it. But that was the time when, like, the military gave out tobacco and cigarettes or whatever. But when we look at some data as to who smokes now, and in this particular study here, we see construction and blue-collar workers, higher likelihood of smoking, right? And when you look at those with the lowest education and the lowest income, highest rates of smoking. When you look at this, I think this was a study in Hungary. In fact, my wife and I were just in Budapest just a couple weeks ago, a great city that was. When you look here at this stepwise increase in smoking rates according to education, so the lower your education, the higher the likelihood of tobacco consumption. The higher your education rate, the lower the likelihood of smoking, right? And then these are looking at US studies, and the studies were the same. Those with high school educations had the higher likelihood of smoking, and then the same thing with poverty and looking at income as well. So these are examples, to me at least, I see that as how tobacco and education are related. Lower the education levels, the higher the likelihood of partaking in something like tobacco, smoking, that will be deleterious to your health. And we'll talk about in a minute who it is that are those that are unlikely to be educated in the US. I was not a fan of the ACA. I still am not. I think the ACA brought us from, on a scale of 1 to 10, I think we started at a 0. And maybe moved us to like a 3, 3.5, maybe, I think. The reason why there was some movement forward is that there was this potential of a single-payer system in the horizon, and I was kind of looking forward to that. But the removal of a common system of Medicare for all, and the fact that President Obama at that time did not start with that, I criticized him regularly on WHIV, and as we did regularly. But one thing it did do is that it did, at least in this study, show some effects with equalizing socioeconomic status. So those people, and what this study is basically showing, if you look at those that are insured by socioeconomic status, that it did start insuring people. And you started to see a closing of the gap a bit. It wasn't a lot, it was a bit. But I will say this, the majority of my Ryan White patients, did this happen to your Ryan White client? Are you guys physicians? You guys are clinicians or no? So Ryan White is so for my patients that were on what we call a Ryan White program, they moved from being on Ryan White, they all got placed on Medicaid, and then once they were on Medicaid and they realized they were all being nickeled and dimed for this and that or whatever, they all went right back to Ryan White again, right? It was just it was easier for them. They'd rather be uninsured in the Ryan White world where they were never nickeled and dimed. They never have a copay to come see me. None of the medications I give them do they ever have any? I write grants, so they recognize when they came to me and they were Ryan White, they never got nickeled and dimed. The minute they got into Medicaid, I refused. I paid for their copays, so I had grants that paid for their copays, and we have grants that pay for their medications when they go to the pharmacy, and we send them to specialized pharmacies. But if they went to the ER, if they went to this or that or whatever, everything was being nickeled and dimed, right? And so you had a lot of people who jumped off of that system. But it did help. But in the end, really, we really just need to, I was asked by the Huffington Post to write this, which was to repeal the ACA when they were talking about repealing the ACA last year, and then I said repeal the ACA and just replace it with Medicare for all, and this got a lot of traction. But let's talk about where our society is, though, all right? And if you look here at this line right here, from the 50s all the way until about the 70s, this is looking at productivity and hourly compensation. Productivity and hourly compensation were almost 1-to-1, right? So from 48 to 73, productivity was 97%, wages were 91%. When you look at 73 to 2016, so this area right here, you can see productivity went up spectacularly, something like 75%, where wages have remained stagnant at about 12%. And that's America today. This is America. This is the quintessential definition of America. Those at the top are winning. They're doing great. I mean, look at American productivity. As American workers, we've been doing an amazing job of being productive, but we have not been fairly compensated for it. And then when you take that and look at what healthcare looks like, right? And I try to share this with my colleagues all the time. Deductibles have gone up significantly. Premiums have gone up significantly. But look at wages have remained stagnant. And it's the delta between deductibles and earnings. It's that difference there. That's where our patients live. And when we talk about social determinants of health, that's where social determinants of health live. We know what the right thing to do is. We're just not doing it because our healthcare system is based on profits, period. End of discussion. This is probably the most devastating slide that I have in this slide deck. And what this slide is basically showing is that we can now predict life expectancy. Obviously, we've known that it's been separated by men and women. We can now predict life expectancy according to income. So the richer you are, the higher life expectancy you'll have. The poorer you are, the lower your life expectancy will be. And that's separated anywhere between 10 and 15 years. So now income can now predict life expectancy. So let's talk about really another great example of structural racism in healthcare. And this was the New England Journal. So that was, a lot of that was Lancet. I just took you through the 5 articles that the Lancet basically walked you through. This is the New England Journal, who then in response published something in August of 2017. Now, I never thought that the New England Journal had it in them to do it, so I will give them their due. They actually did publish this, and I was really impressed by this. This slide here is talking about Hep C virus, so HCV treatment. I thought I was talking to more healthcare, so forgive me for using some, I'll try to break open some of these acronyms here. HCV is Hep C virus, a tale of 2 epidemics, VA and IHS. Let me just stop here and just say, do you guys know that we already have 4 single-payer systems in the US? We do have 4, we know they work. Right? This is not a mystery as to whether or not it works or not. They work, right? What are the 4 single-payer systems that we have? Well, I got 2 of them up there. Veterans Administration, IHS, Indian Health Services. I had 4 years living on the Navajo Reservation after residency, doing my public health service payback to the government. So I know the IHS very well. And then we have 2 more. So we have Medicare. And what's Medicare? Medicaid is a very broken one. But yeah, I hear you on that. We have 1 more after that, which I never even actually knew. It's the Department of Defense, which I didn't know. I was actually in San Antonio 6 months ago when I was giving the same slide, and someone from Department of Defense was like, "Excuse me, we have our own." I was like, "Ooh, my bad. Don't shoot. Don't shoot." I'm like, "All right, I promise you I will say 4 from here on out." And I have. All right, this slide is basically showing, were we able to get a, here, just put it right here.
I was going to be your backup.
Thank you. And where is it? There we go. Let's see.
Can you give it to me?
Where we go? All right. All right, yay. So this line, all right. No, I hit this. I thought that was a, is there a pointer on it? Is this the pointer? All right, there we go. All right, what we're seeing in this line right here is that this line here is looking at the populations with the highest rates of Hep C. The populations with the highest rates of Hep C are First Nation peoples. All right, and that squarely has everything to do with poverty. Now let's break this down, all right? So this is now looking at the VA and IHS, right? So let's go. So when you look at the per capita spend of healthcare for the VA, they won't tell it to us. Our government will not tell us what the per capita spend is for the VA. For IHS, it's $3,688. How much did I tell you the rest of the world is? 5,000. What is it in the US? 10,000. General population, 10,000. Look what the First Nation peoples get. Right? Structural racism, right there. All right? When you look at the mortality, again, New England Journal. This is new. This is not some like crazy left wing, like this is the New England Journal, right? Mortality of Hep C treatment, right? They won't tell us. For the IHS, for First Nation peoples, it's 13 per 100,000. The general population, by comparison, is 4 per 100,000. All right? When you look at the total budget, this is the total budget for the VA, it's $59 billion, and they added $2 billion for Hep C treatments. It's $5.7 billion for IHS, whereas the VA has 4 times the number of patients, but 10 times the budget. 10 times the budget that IHS has. When you look at the cases of Hep C, 2,000 versus 80,000, right? And of course, the 200,000. That 200,000 is going to be covered. They're going to all be cured in a couple years because of that extra money. Whereas when you're looking at the IHS, it's going to take decades, and yet they are the highest rate, right? They're dying at the greatest mortality, and yet there's still no commitment for Hep C monies for the First Nation peoples. And when you look at Hep C treatments on the formulary, they're of course on the VA, they're not on with IHS, and as somebody who worked with IHS, I can tell you that that makes a big deal whether something's on formulary or not. So this was their assumptions, or conclusions rather. The current disparities in Hep C resources and mortality give the appearance of neglect, at best, and institutional racism at worst. American Indian nations deserve the same quality of care and the same level of resources as the VA. So this is a great example of what institutionalized or structural racism in medicine looks like in the United States. And again, that is the VA. This here, without question, is the quintessential definition of institutionalized racism or structural racism in healthcare, and this is looking at Tuskegee syphilis experiments, in which took place from 1932 to 1972. And let me just kind of go over these real quickly with you. Essentially, you had about 399 men that were tested positive for syphilis in 1932. These were all black sharecropper farmers. You had about 201 that tested negative. And the idea was to follow them for 6 months. After 6 months in 1932, they just extended the study for 40 years. Now, in 1932, syphilis was considered, it was called bad blood. That just was the term. It wasn't really described to individuals what the bad blood actually was. What is most shocking through this, however, was in the interim, somewhere in 1952, so about 20 years after the discovery, or after the initiation of the Tuskegee syphilis experiments, 1952, what was discovered? Penicillin. What's the cure for syphilis? What's the cure? Not the treatment, the cure. Cure. It cures, it kills the bacteria, right? Penicillin. That was known by like 1955, except for these guys. And they watched them for another 20 years after that until 1972 when this study broke in the New York Times. And from that, they found that there was a total of 28 men that died from syphilis, 100 dead died from complications. There was 40 secondary infections. In other words, that there was 40 infections that was passed on to intimate partners, and then from that, 19 tertiary or congenital births were passed on as a result of that. Now, as shocking as this is, and it is shocking, and I think that needs to be talked about every time that there's a lecture about this so that we never forget. Tuskegee is about, well, from where you guys are, it's probably far. It's 5 hours from where I live. So I go out there, and I go to the museum, and I interact with Miss Nicole, who is the Fred Gray's daughter. Fred Gray was the attorney who was actually Rosa Parks and Dr. King's attorney in Montgomery for the bus strikes. He was the attorney who tried this case as well. He's still alive. He's 87 years old. And I think it's important for everybody. If this is stuff that's interesting to you, I think if you went to Alabama, go see the Legacy Museum. Have you guys been to the Legacy Memorial? Yeah, it's very, very powerful. And while you're there in Montgomery, take a quick trip to Tuskegee and go see the museum. They're very proud of the work that they're doing there with making sure that this is not something that's forgotten. This is a little bit of an older study in 2005, but the effects of Tuskegee are felt daily. I feel them every day, right? And especially amongst the population that I work with a very marginalized population in Louisiana, in New Orleans. New Orleans is one of the poor, Louisiana is the poorest state, as I showed you, with New Orleans being one of the poorest cities. And then, of course, my population, which is mostly Hep C, HIV, IV drug users, are of them the most marginalized. But this is something, especially when I was in the hospital, I would see a lot. And on this survey here, which was 100% surveying African American people, saying that 60% of those believe that HIV information was being withheld by the government. 48% believe that HIV was quote-unquote man-made. 53% believe that a cure for HIV is being withheld 43% believe those who take new HIV medications are guinea pigs for the government, and 27% believe that HIV was produced in a laboratory. To this day, I still hear that. Right? I still hear some iterations of this. All right? And I take a moment to acknowledge Tuskegee. I know where that's coming from. And I take a moment to acknowledge it. I take a moment to acknowledge their distrust. It makes a lot of sense. I completely understand. We're going to feel Tuskegee for generations and generations to come. And it's deserved. It's deserved. It needs to be felt. Okay? And this is just one of a handful of studies. This is one that was straightforward for me to make a slide. And the other reason why I used it was this was an older slide, 2005. When you look back to 1997, President Clinton gave a formal apology to the 1 or 2 remaining survivors of Tuskegee, including the family members that were there, and just kind of formalized on behalf of the U.S. government for the atrocities. But let's just be very clear. 1972 to 1997, that should have been apologized for the day after that New York Times article came out, is really what that should have been. And I'm quite frankly tired of like, wait. Like, things need the fierce urgency of now. We need to start doing things now, right? So let's talk about social determinants and social determinants of HIV in particular. This is a complicated slide, and I purposely have left it complicated to show all the various entities that are involved with what we refer to as the social determinants, right? We're talking about inequality, we're talking about income inequity, lack of economic opportunity. You add in all these other iterations of incarceration and consumption and survival sex and lack of hope and smaller sexual networks and all of that leading directly to increased HIV risk. Now, I can make the same slide, erase that, and then put in Hep C. Exactly the same. And we're going to talk about Hep C on a smaller scale after we do this HIV. So when we look at social determinants for HIV, these are some low-hanging fruit studies that basically looked at countries in Africa particularly, and those that were the low-income levels of countries by African standards had higher rates of HIV. All right, higher rates of HIV. So income was linked. This is a study that was done in the U.S. This was a study that was, it's still shocking to me. I have read out this study maybe 100 times since it came out in 2014, and I'm still shocked by it every time I saw it. This was a study that showed that when you looked at inequality, poverty, and segregation, you had higher rates of HIV. So in communities that felt, in the U.S., communities that felt that were the most financial or had the highest levels of inequality, highest levels of poverty, and the highest levels of racial segregation had the highest rates of HIV. That right there, I could just end the conversation. Social determinants, right? Structural racism in healthcare right there, right? And then this is that Gini coefficient that we talked about before, and this is basically looking, again, at levels with, and this is again looking at Africa, and those countries that had the highest levels of financial inequality also had the highest levels of HIV as well, highest levels of HIV. This is a study that just actually came out, look at 10 of 2018, this just came out just about a week ago. I added it here. And it was really good because what I liked about it was that we're really kind of driving home this idea of poverty and poverty in infectious diseases and poverty in HIV particularly. And this study basically showed that those individuals who experienced household food insecurity were more likely to test positive for HIV at these collection of clinics in KwaZulu-Natal in South Africa. So they had 3 clinics. They set them up. They also asked for food insecurity. They found that those that had the highest levels of food insecurity at home also had tested positive for HIV, again, showing that link. Let me be very clear. New Orleans, 40% of our children experience food insecurity. 40%. It's still, I'm blown away by this. So these are the social determinants of health when it comes to HIV in New Orleans. There's 5, and those are the 5 that I talk about regularly, right? It's illiteracy, poverty, STI, sexually transmitted infections, homelessness, and incarceration. In New Orleans, we have the highest rates of illiteracy, right? We have the highest rates of poverty. We have the highest rates of sexually transmitted infections. We have the highest rates of homelessness. It's gotten better. And then we also have the highest rates of incarceration. And so it should be no surprise that we have the highest rates of HIV. And this is what this Time magazine article here says. New Orleans, Louisiana has the second highest rates of new infection rate because of poverty, stigma, incarceration. Oh, and of course, how could I forget? Duh. Abstinence only, right? Yeah. Let's put kids out there, young people. So I often say, breathing, the highest order function that humans can do, right? You need oxygen to live, right? But for me, myself, I believe, and this is my personal belief, that the sole function of a human being, although this hasn't been my experience, because like I said, I just got married, and this is unlikely to happen for me, but the sole experience of a human being is to reproduce, is to pass genes. That's why we're here. The fundamental element of what we do is to pass genes, right? So breathing is needed so that you can exist to pass genes. How do we pass genes? Through sex, right? And then this idea of abstinence only, the science is overwhelming. It's like climate change. It's like gun violence. It's like all of these things. They know. I've stopped going to the state. I mean, I will if people really ask me to do it. Like I did it for marijuana, because they were still movable with marijuana. But they know the science. I mean, look what's happening right now in the Supreme Court. They know. They just rushed through that FBI job, right? They just rushed right through it. They know. They know. They're just ignoring it purposely because they already know what they want. Yes? There's going to be a vote tomorrow. So there you go. Yeah. They know. So who was it? I'll look at it. Joe Manchin, a Democrat. There you go. Joe Manchin, a Democrat. They know. They just choose not to listen. Abstinence only. Same thing with abortion and reproductive rights. It's the same thing. It's all meant to hurt. It's all meant to inflict pain. It's all meant to keep us down. That's what it's all meant to do. There is no real acknowledgement of science. We all know the climate is changing, but ignore it. And say you have senators that walk in like all smug. I'm going to show President Obama I got a snowball. Did you guys see this guy? I got a snowball. It's snowing. Like, oh, dude, really? Wow. Oof. Like, you are emblematic of old white dudes that need to go, like in the Senate, right? You just need to go. By the way, what gives me hope is millennials. Who are millennials? I see some millennials here. You guys are the ones that are going to save this country, if not save this world, all right? Grow up and please take over already, all right? African Americans make up 12% of the population, but they make up 48% of new cases for HIV. This is just one number. Other numbers I've seen have been higher than that. I use this one just because it's from the CDC and it's a bit lower, right? Limited access to quality health care, lower income, educational levels, and higher rates of unemployment place some African Americans at higher risk for HIV, and that's ultimately what we're getting to. So let's talk about illiteracy. So Louisiana has the lowest rates of literacy in the country. In Orleans Parish, up to 1/3 of children or young people who graduate from schools don't know how to read. In fact, we have a saying in New Orleans that we need to, one of my shows I do is with one of my colleagues. His name is Doc Griggs, and Griggs reminds me regularly that oftentimes that we have to talk and say things at a 5th grade reading level. And he reminds me, and we are reminded, and we amongst the professional class, if you will, in New Orleans, we are constantly reminding one another that we forget, that it's easy for us to talk amongst ourselves, But to talk effectively to those individuals, in New Orleans, 1/3 of people, effectively, if you take that confidence interval all the way out, 1/3 of them don't know how to read, lack basic prose. This was a study that was an unpublished study. I regret not having published it. We submitted it to AIDS, and so my wife went and did this, and she went to the AIDS conference at DC. After this study, my wife and I wrote this study, the Ebola outbreak happened, and I went to Sierra Leone, and then our house flooded. New Orleans, fun place to visit, hard place to live. So I took my eye off of this study for a while. And when I was in Sierra Leone, we tried to submit it, and I will probably always regret not finishing the study, and I will at one point do something to finish the study. Essentially what we did is my wife and I took what's called environmental data. So environmental data is not data from the environment. We took data from different sources and basically standardized it. So that's referred to as environmental data. We took data from the environment, standardized it. So we went to like CDC sites. We went to places that had very, very high level data that could be trusted. Of course, there's a lot of error in there, and that error was accounted for in these statistical studies. But essentially what we did was we took the states that had the highest levels, we just took all the states and ranked them to abstinence-only sexuality education. We ranked the states according to the number 1 to 50 levels of adolescent HIV. And then we took the states whose public school system leaned more what we refer to as black or more as we refer to as white. So in Orleans Parish, none of my colleagues send their kids to public schools. That's just the reality of the situation. That was the first thing that struck me when I moved to New Orleans 15 years ago. None of my colleagues, I am a product of the Los Angeles school system, very proud product of the Los Angeles school system, went to UC Santa Cruz, very proud of my college education as well. In Orleans Parish, that's not the case, right? So we then put it all into a statistical analysis. I did the statistics myself first, and then I took it to Tulane Epidemiology and had them repeat the statistics. They did it in a fancier statistics. I got my degree in statistics in 1992. They said, we have much more updated statistical things. Dr. Dery, we're going to redo this. And they did. We got the same results. And essentially what we saw was that those, again, this was non-peer reviewed, right, non-peer reviewed. What they showed was that those states that had the highest rates those states that had the highest levels of adolescent HIV, Louisiana number 1, New Orleans number 1, highest rates of adolescent HIV in the world, Orleans Parish, right? Those states that had the highest rates of adolescent HIV tended to have schools that were more, public schools that were more black, and therefore taught abstinence-only education. That is an example of structural racism. That is a quintessential example of structural racism, right? And this is, and we wonder, I'm shocked. People have HIV in New Orleans, right? Or I'm shocked we have high rates of HIV in the South. This is, again, this is how these systems work, right? When you look at the school quality and you look at the race gap, right? So in areas where parents with college-educated parents, so even with college-educated parents, the race gap exists with schools. So black children tend to attend academically weaker schools, right? So looking at STIs, I'm very proud of this, heading right here, mapping STIs across Louisiana. New Orleans named the most sexually diseased cities in the nation, and I'm proud to have been prominently featured in this article. They were like, Dr. Dery, can you explain to us why we have the highest rates of STDs in New Orleans? I was like, very easy. Illiteracy, homelessness, poverty, abstinence-only sexuality education, incarceration. These are the reasons why we have these highest rates of STIs in New Orleans. New Orleans has the highest rates of STIs. There we go. And then right now we are the number 1, and pun intended, we are the hotbed of syphilis. Right now we are number 1 capital of syphilis in the world, with gonorrhea and chlamydia as well. There's so much syphilis in New Orleans, like it's easily 1 in 2 men who have sex with men in my clinic, probably even more than that, like almost, sometimes it's 1-to-1. Sometimes it's 1-to-1. The rates of syphilis, I go through so much penicillin, like in my clinic. I'm like, oh, penicillin allergy? Yeah. You know, shot. Like, there's so much syphilis right now in New Orleans, and again, this is mostly amongst the population that I work with. When you look at STIs amongst racial or ethnicity, what we're looking at here are rates of STIs by race and gender. So these are men, this is women. Follow these red stars. This is looking at African American populations right here. So you're going to see a couple slides like this, right? So chlamydia, highest rates amongst men and women who are black. When you look at gonorrhea, highest rates amongst men and women who are black. And again, when you look at syphilis, again, highest rates amongst men and women who are black. When you look at the use of PrEP, PrEP is this opportunity for us to prevent HIV, right? And PrEP is a pill. It's one of the HIV medications that we use called Truvada, and we give it to people who are HIV negative to prevent them from becoming HIV positive, right? So it's called PrEP, pre-exposure prophylaxis. So pre-exposure prophylaxis, when you look at those people, so it's been very, very helpful, very, very useful, the idea of being able to give people HIV medications, un-HIV medication, Truvada, before they, to help prevent HIV. It sounds like a crazy idea, but it works. It's wildly effective, right? It's wildly effective. And we're going to talk about PrEP in a moment, right? But when you look particularly at Black and African American and Hispanic and Latinx individuals, only 1% of African Americans who are eligible and only 3% of Latinx individuals are actually on PrEP right now. Structural racism in medicine right there. Another easy to define and easy to see example of structural racism in medicine. Who is more likely to get HIV? Right now, this is still and has always been the case. Black men, men who have sex with men, highest rates of HIV in this country. Period. End of discussion. If you're a black MSM, MSM is just another way of saying men who have sex with men. If you are a black MSM, you have 1 in 2 probability of getting HIV in a lifetime. 1 in 2 probability of getting HIV. This is essentially just looking at poverty and HIV diagnosis, and this kind of drives home something that we've talked about several times, which is that these were studies that were done in the US, and those that were living in very high poverty homes also had far higher rates, both with men and women, likelihood of developing HIV. This is looking at a study that's basically looking at black men and looking at income disparities amongst black, white, and Hispanic individuals, and those that were black MSM, these were the men who have sex with men, had the highest rates of HIV. And these were also those individuals. They accounted here for, was this, yeah, no, this is just accounting for just straight up, just MSM population. So again, just driving home the same thing. This is amongst women. Look at that, that's heterosexual contact amongst women. Right now, black women, highest rates of HIV, growing population. The #1 killer of black women between the ages of 25 and 45, HIV. Think about that. Something that could be completely preventable. And this gives you a very good example of that. When you look at those individuals that are prescribed HIV medications, right? That are prescribed HIV medications, and this is, when you look at those individuals that are prescribed HIV medications, with black population being that this blue line, black individuals least likely to be prescribed HIV medications when compared to white. When you look at black MSM, also far less likely to be given HIV medications. And when you look at viral suppression, so viral suppression is very important for HIV, right? When you look at viral suppression, you see again also that amongst the black population, you have far lower rates of viral suppression, and then far lower rates of viral suppression amongst men who have sex with men. I said it was a hard lecture, didn't I? I started by saying this is really heavy, right? Poverty, we have the highest rates of poverty, right? When you look at poverty, poverty in Louisiana is greater than the rest of the country. When you look at childhood poverty, we have the highest rates of childhood poverty compared to the rest of the U.S. When you look at poverty rates by race, it should be, it's not a shock, total poverty amongst African American individuals are much greater, and childhood poverty amongst African American individuals are much greater than white. When you look at wealth, the wealth gap that exists, still sticking with this idea of poverty. This is where the Great Recession occurred, right, in 2007, right? So prior to the Great Recession, you had a huge gap of wealth. I mean, this is what, these are average African-American families in the U.S. Prior to the Great Recession, the average wealth accumulated in any black home was $19,200. After the recession, it was $11,000, right? And you could see that compared to white wealth, it was 13 times greater. The system is meant, it has the thumb on the scale for success for white people, and the system was developed purposely to oppress and suppress those individuals that are not white. And the economic system that we have, the healthcare system that we have, it was purposely created to get outcomes like this. This was not done by accident, right? This is not the bug in the system. This is the system. This is the system. Middle-class children, most middle-class children are downwardly mobile when compared to corresponding white children. When you look at homelessness, again, homelessness in New Orleans is a lot better than it was, but that was as a result of a very coordinated effort. It was also a lot of veterans living under, as I'm sure it's not unlike what it is in San Antonio. Of course, people who are homeless are going to go to warmer areas, and so New Orleans being very, very warm, and our bridges being an ideal place. We had a lot of vets, so there was a lot of money that came in initially for veterans, and then it just spilled over into non-veterans. But of course, it should be no surprise that we have some of the highest rates of homelessness, and of course that it just kind of runs the gamut. This is something that was really quite shocking to me, that after Katrina, in 2010, greater than a quarter of Louisiana was homeless. Greater than a quarter of Louisiana was homeless in 2010. And that was the 10th worst in the country. That was the 10th worst in the country, right? Should be no surprise that when we look at household food insecurity, black families have greater food insecurity when compared to other races and ethnicities. And then, of course, this one takes the cake. The incarceration, the carceral state that we live in is unbelievable. And I have to take a second and stop and make the acknowledgement, sort of like I did at the beginning of this lecture. Are people in Louisiana jails, do they look like me? No, of course not. Okay? And again, this is not a bug in the system. This is the system. And we're going to talk more about that in just a moment. Of course, this goes back to the slide that I showed you earlier. We talk about unanimous juries, right? And the importance for us to reverse these unanimous juries. But for us to say that did not have racist beginnings is being blind, because here it is right here. The Advocate found this in a newspaper, an excerpt from the official journal of the proceedings of the Constitutional Convention of the state of Louisiana in 1898. And I will say it again, our mission was, in the first place, to establish the supremacy of the white race in this state to the extent to which it could be legally and constitutionally done. It was codified into law to get those results, right? It was codified into law to get these results. These people would not be in jail if it were not for the constitutional amendment. So let's say this constitutional amendment passes in November, right? Which we anticipate it probably will, although I'm not a superstitious guy. But I did just knock on wood. What's going to happen to those 402 people? They're going to stay in jail. That was part of the way that the GOP in Louisiana said, okay, we understand moving forward, we can't be part of it, but they still have to stay in jail. Right? We also have a very vibrant, say it with me, privatized system. I'm in Texas, so I recognize that you guys have a very vibrant system as well. Yes, ma'am. Yep. 13, right? Yep. Right. So if what I'm talking about is something that's interesting to you, you have to read the book, Michelle Alexander's book, The New Jim Crow. The person, I think it was Ava DuVernay. What is it? DuVernay, right? She was the one who directed Selma. She directed this excellent documentary on Netflix called 13. It's talking about the 13th Amendment. It's talking about the abolishment of the 13th Amendment, but the abolishment of the 13th Amendment basically written into it was, well, yes, there should be no slavery, except if people go to jail. And if the people are in jail, then yes, you can utilize those prisoners as workers. And now we have some American luminaries, such as Victoria's Secret and The Gap and various other corporate entities that profit significantly off of this labor that occurs in our carceral system. And we're going to talk more about that as we move into kind of drug abuse. But when you look at annual marijuana use by race, there's no difference in annual marijuana use between black and white people, right? So black, white, smoke marijuana, utilize marijuana to the same rates, right? But I'm sure you're going to be shocked. Look at that. Who goes to jail more? Right? I'm sure it's shocking, right? This is not a bug in the system. It's a feature. This is the system, right? This is the system. And this is how our rates of incarceration. So in the state of Louisiana, local prison, we have more inmates in local prisons than any other state because sheriffs get paid $25 a day to keep people incarcerated. So the state actually pays people. So when you go back to those individuals that had those non-unanimous jury verdicts, the reason why the politicians did not want to let those folks go, because they really should have gone, because they would not be in jail if we had a unanimous jury, is because the sheriffs would have lost money. And that's their constituents as well, because they get paid by these individuals through these legalized form of bribery called campaign donations, right? We need to get rid of that. And by the way, person running for Senate in this state is campaigning for that as well. So I please encourage your people to go out and vote. I'm sure y'all will. So what does structural racism look like, the opioid syndemic that we're having right now? So what's the word syndemic? Syndemic is the combination of two words called synergy and epidemic. So synergy is when two things come together, and it's the greater, the sum of the whole is greater than an individual of the parts, right? So, for example, I graduated from high school in 1986. We were the class of synergy. I didn't know what the word was until I was 18 or 17. And now I see this word syndemic all the time, very handy word to know. It's the combination of a epidemic with synergy. So it's called syndemic. What are the components of a syndemic? Now, it's the opioid crisis that we have with hepatitis C. Because everything I just talked about with you a moment ago with respect to HIV, we're now going to just peel that skin off, and I'm going to show you the same trends as it applies to the drug policies that we have in the United States, and the drug policies being another quintessential example of institutionalized or structural racism, as well as hepatitis C. Do you guys want to do a quick break? Everyone's kind of rumbling in their seats. You guys want to do a quick break? And then, yeah, let's do a quick break, and we'll come back in, like, let's say, 10 minutes. So I'm going to kind of jump through these next set of slides. This will be a very quick, because I do want to leave on some positivity. And I also want to leave on kind of, I wanted to talk a little bit about some of the things that I do outside of medicine that I think kind of will leave on a sense of positivity in lieu of all of the heaviness that this lecture kind of brings out. So I'm going to just jump through slides. This slide is basically just showing it's no, like we know if I could write policy, I'd write policy that would reflect better housing, education, needle exchange. We know amongst those people who use IV drugs what is more likely to push them toward behaviors that would increase the likelihood of HIV transmission. I cannot catch a break here, huh? This was just working a second ago. This was just literally working a second. Yeah, all right. This slide here is just basically just saying that that the opioid crisis that we are seeing now and that you guys are hearing so much about has brought down the life expectancy. Think about that. The opioid crisis, 200 people die a day of IV, of overdoses. But it's not just IV overdose. Let me tell the story of my very close friend who was a board member for my nonprofit and started the radio station with me, WHIV. Vice president of her bank she had chronic back pain from an accident. She broke her neck and her back. She took one opioid pill. She took, for some reason, we don't know why, because she's deceased, she took 2 different benzos that were not prescribed to her. All right, 2 different benzos that were not prescribed to her. So she took her pain pill that was prescribed to her. She took 2 benzos that were not prescribed to her. Again, we can't ask her why. She took her antidepressant. She took a cold medicine. And she drank 2 glasses of wine that night. All right, and that's how people are dying. It was obviously this is an incredibly tragic loss. It's still tragic. It happened 2.5 years ago, and her absence. We all have been touched by this. 200 people die a day of this, beyond just those that are in the opioid epidemic, and it's brought down the life expectancy. 72,000 people died in 2017. This is not reflected on the new statistics. This article just came out August 15, 2018, right? So we now are in a situation, we are seeing the highest levels of opioid epidemic. And again, it's not everybody just shooting up, right? A majority of these losses are what happened to my friend. That's a majority of how it's this co-administration of a benzo, an opioid, and alcohol. And when you add in marijuana and benzos and marijuana and opioids, it's a whole other level of issues. I'm very, very pro-recreational marijuana use. I don't think that is part we need to abolish the federal laws for marijuana, because I think it helps, that feeds the carceral state that we live in. But there is data, there is noise, there's epidemiologic data that's showing that the co-administration of benzos and marijuana, we're seeing higher levels of death. So we just need to be very careful about that. I like showing this slide because just to help doctors get out of their minds. So I'm Gen X, right? Born in 1968. Kind of started coming into my own somewhere in the late 70s, early 80s. And I remember a time when there wasn't the DARE campaign and the Just Say No campaign. I remember those days vividly. And then I remember when those days came. And then after, I remember the media campaign hitting me with what images of the drug user look like. Imagine in your head who that drug user is. Get that image out of your head and forever forget about it, okay? That was created by media. That was created to scare us, right? And it was very, very effective, okay? So people who use drugs, and this is what I share with my physician colleagues, is these are our patients. These are our individuals. And in fact, we are going to see a lot of these folks come out of the woodwork now with the treatments of hepatitis C that we have, right? The longer you use IV drugs, the higher the likelihood of hepatitis C. I don't have this slide in this slide deck here, but it's 100%. 60% the first 10 years you use IV drugs, and then it goes stepwise to over 30 years of IV drug, you have 100% likelihood of acquiring hepatitis C. There's 1.2 million people living with HIV in the US right now. There's 3.4 million people living with hep C. It's a far greater problem. And so I train and I talk to my colleagues that when in the 80s, when HIV was a thing, right, and people were like, ooh, right, because people were gay, or they used IV drugs, or what have you, the 3 H's of HIV. What we're seeing now is a similar time. And that's why you're seeing a lot of infectious disease doctors now starting to get into and taking on the mantle of fighting the opioid epidemic as well, because it's very similar to what the early HIV days were like. So this is really kind of a set of slides that help my colleagues understand what harm reduction is and the importance of harm reduction, right? And the idea that not every problem is solved by putting folks into jail, right? This is what the US looked like in 1999 in terms of opioid overdoses. And this is what it looks like now. It has now pulled down the life expectancy. For those of you who do research or who are for statisticians or math-oriented, the idea that one problem, 200 deaths a day, 72,000 deaths in a year, is so significant that it pulled down the life expectancy. That to me just like, whew, that's pretty profound, right? So, look at this. In 2012, nearly 1 in every 100 American adults is in prison, right? 2.1 million from 1980 to 2000, the number of children with incarcerated fathers, right? And look at the carceral state that we live in. 4 times growth in the past 4 decades, right? So, look at that. We're at the highest levels of opioid epidemics. And then look at that. We're at the highest levels of incarceration. To me, this, I don't know, maybe call me silly. Could this be driving that? Ooh, I don't know. Right? I wonder, in light of everything else that we talked about. Yes, of course it is, right? And here's the most shocking thing of all, and this goes back to your point back there. This is so this is one big infographic that I couldn't fit into one slide, right? It would come down to here, so I had to cut it up. $182 billion industry is the prison industrial complex that we have. If you, listen, I'm the first person to kick the stool under a system and watch it collapse, right? Especially one that's not fair and that has been very harmful. But if you kick that and take that away overnight, the whole American economy is going to crater, right? So as rapidly as we need to abolish the prison industrial complex, and I am for abolishing the prison industrial complex. I went to Iceland. I turned 50. My wife and I went to Iceland in April. While we were in Iceland, the biggest story in Iceland while we were there in Reykjavik was one of the biggest users of bitcoins are in Iceland, right? They have a law where Bitcoin, so a lot of people have moved to Iceland to be able to do their internet scams using Bitcoins. And this guy, he was Icelandic, and he had just I can't remember the details. Anyway, so he was caught for doing whatever he did, and it affected different continents like Africa and South America and whatever. The Icelandic authorities went and put him in jail. You know what jail in Iceland is? It's a condominium. Kid you not, it's a condo with no guards or anything. You're just told to stay inside, and they do. And a prison break is they just leave and they go to the bar and they get drunk and they come back in. That's allowed, with the understanding that you're going to come back to where you're going to go. But the idea of rehab is very, very much like, why did you do what you did? And they go in and they rehab. That's okay. So the reason why this guy was a particular story was that at the same day that we were there, my wife and I were there, and we were giggling over the story, the Prime Minister of Iceland goes to Sweden, right? So she gets on a plane and goes to Sweden and sits coach, right? Which is great, like that she goes on a commercial airline, sits coach. The guy who was supposed to be in jail, the Bitcoin guy, he escaped, walked onto because you don't need to show a passport to go somewhere else in Scandinavia. You could just show your license. He walked on the plane, sat first class. The prime minister was sitting behind him, and he made a prison break, and that was the big scandal in Iceland while we were there, right? Compared to what we have here. And this is very much what you were talking about, that a lot of the, just look at all of the elements, and again, Michelle Alexander's book, The New Jim Crow, talks about this in great detail, far more eloquently than I could ever. But talking about the hidden classes or the second and tertiary classes that we create as a result of people who are incarcerated, all of the areas in which these individuals are nickeled and dimed. They pay for every element of their life once they leave the incarceral or the carceral system, including any sort of probation, any this, any that. Of course, phone calls are like $8 a minute, and there were some laws to try to reverse that. I think President Obama may have tried to reverse that, and I think President Trump, reversed that. I think, yes. I don't know if it includes immigrant detention, but that's a whole other, and I did not want to bring that up here to you guys, because you guys are the experts. I talk about it a lot, and I go around the country talking about it, but I was not going to bring that here, because that's not my level of expertise. But I will say this. Red and white programs are what keep people living with HIV alive in the United States. To ramp up the detention centers here and around the country, they tapped into Ryan White dollars to pay for that. I'm going to skip some of these. There's other countries that are doing it better, obviously. Portugal does it the best. And these are just basically same. These are just, this was a slide from 2016. We don't have the 2017 slides yet, but basically this says 116 die every day. Now we know it's 200. There's just a lot of people dying. When you look at acute Hep C cases, they were going down up until the economic turn. And then as a result of the economic downturn, you see an uptick of hepatitis C, which goes directly with the uptick of what we see with the use of IV drugs. This is only going to get worse, and I am part of that problem. And I will explain to you how I am part of that problem. I run HIV clinics in New Orleans through this FQHC called Access Health. My clinics are schedule-free clinics. In other words, we don't prescribe any scheduled medications at all. And the reason is that's just easier to say no on a policy-wide level than it is to say no at a person. I'm like, oh, well, it's our policy. We don't do that, right? So I'm part of that problem that's making this happen. I acknowledge I'm part of that problem, right? But I can't solve that problem. Now, the Louisiana State Board of Medical Examiners are coming down appropriately, so I'm sure the Texas Board, in fact, I'm sure all the state boards are coming down very, very hard because of data that I think I'm going to show you in just a second, showing you that a majority of the overdoses that we're seeing are starting from doctors' offices, okay? Because where are people getting their medications? Doctors' offices, because they know that are there any doctors in here? We're kind of suckers, and it's hard for us to say no, and they know how to push our compassion buttons. These are professional these are folks at doctor shop. There's a lot of obstacles that are up now that stop a lot of that, right? And I'll tell you what, I mean, for me, I'm proud of my ability to kind of smell a seeker. There's red flags that pop up 2 minutes into the story's not consistent. They're paying the things that they're saying. The tip of my hair hurts. I mean, just things that are like physiologically impossible to like, right? I mean, I've stopped, and so because I've stopped, and I think when I stopped doing scheduled medications, I think I had five folks that were on chronic pain medications, right? Legitimate injuries, chronic pain meds, whatever. When I stopped, I had 5 people, and I sent them out to pain medicine doctors. I saw the writing on the wall, right? So I was able to get them in now. Try to get somebody into a pain medicine doctor now. It's impossible because a lot of other doctors are stopping too. And so now people are getting cut. And what do they do when they get cut? They go on the streets. Exactly right. I'm going to just skip through a lot of these slides. These are all just slides just kind of corresponding. This is the slide that just shows that a majority are getting from their physicians. Look at that, 35% obtained directly from their physicians, and another 53 obtained from friends and family who got it from physicians. So that accounts for something like almost, what is that, say 80, is that 85, 90% are starting from doctors' offices, right? I mean, it's quite shocking. And a majority of them, only a minority are heroin. A majority of it is, like we were saying, is a majority of is combination, a co-administration of other drugs. Have you guys seen this care continuums? The care continuums are really important. This is something that started in the HIV world and is now kind of spreading very rapidly to other entities. And in short, a care continuum and when we look at hepatitis C care continuum, the same thing with HIV, is there's a lot of noise in the middle, but I'm going to just give it to you very, very simple for those of you that are non-clinical. These are the people that are positive, and these are the people that are cured. All right, that's an easy way to think about a care continuum. Here, these are people who are positive, who got to care, who started treatment, who finished treatment, da-da-da. So, but it's the vital sign. Every grant that I write now wants to see my clinic care continuum. This has become now a standard of how we measure HIV and Hep C medicine. All right, so this is what the country looks like. These are 3.5, should I say 3.4 million, 3.5 million people living with hepatitis C. Only 9% are cured. Why is that? We know these people, they're diagnosed. Why is it only 9% are cured? Right, cost of medicine, the healthcare system does not want to support this, right? Around the world, countries are making huge strides to cure everybody with hepatitis C, right? Except for the country that invented the medicine. So we're going to look at a bunch of different populations. The ED population, these are the people that are positive. This is like less than, like, I think 2% that are actually treated, SVR, sustained viral response, right? When you look at people who use drugs, right, the people who theoretically need the medication more than anybody else, these are the number of people who are positive, at least in this study. These are the people who've actually gotten treatment, right? Less than 10%. This is looking at needle exchange programs, so people who actually are going into programs and using needle exchange programs. They have the highest rates of hepatitis C you can imagine, and only a incredibly small minority even actually started treatment, right? And so again, this is speaking to, this is looking at sex workers, right? Less than 1% get their hep C treatment, all right? Again, these are looking at populations that are poor, populations that are impoverished, marginalized. This is I didn't correct this. This is not sex workers. These are actually criminal folks that were in the justice system, and again, a small minority actually achieved SVR. Again, this is another study looking at formerly incarcerated people. Less than 6% actually got SVR. And now let's look at a system that actually works, a system that uses a single payer system, the VA. And look at the VA system. So the VA system is, so 2016 is in gray, right? So you have less and less, hang on a second, so you have, right, so what you essentially have is 43% of people in 2016 in the VA system have been treated for hep C. So you have almost 1 in 2 people. So in a single payer system that can actually negotiate medications and it can actually manage these medications appropriately, you've got actually a system that works. And this is the graph that tells the story more than anything else. And this is looking at the number of cases in total of hepatitis C in the VA system, and it's just going down. This is obviously projected data right here. So in a system that works, in a system that wants to make it better, in a system that is designed to try to do the right thing for individuals, it can actually work. So this, to me, this slide gives me hope because it makes me realize we can do it. These are harm reduction strategies. I'm just going to kind of skip through that and then just kind of get to the end in my last 15 minutes here. This is just basically just looking at harm reduction and the importance of harm reduction, why harm reduction is important, and the things that we can do to support our population, especially those that actually inject drugs. We can support them by needle exchange programs. We support them by giving them naloxone, which is an inhalant that can reverse overdoses. The state medical board threatened to take my license away in 2011 because I tried to start a naloxone program in 2011, and they threatened to take my license away. In 2017, they finally got around to actually doing it. So look at the delta between 2011 and 2017. If I have I should probably, I have the frame, my wife made me frame that letter from the state medical board. She's like, you know, you buck the system. Keep that letter up there. But these are needle exchange vending machines. And this is a crack pipe vending machine. That's what harm reduction is, right? That seems shocking, right? Around the world, people are like, yeah, we've got one of those, right? Here, we're like, whoa, right? Get ready for safe injection sites. Safe injection sites, we're right on the cusp of having clinics open so that people can come in and use IV drugs safely. 75% of people who use a safe injection site seek treatment in the first year. Now, we know it takes multiple attempts to get better, or to be cured of addiction. I didn't mean to say to get better, but to stop using. But still, 75% of people who start. And then there's in another slide deck I could go on forever about the monies that are saved in overdoses, the monies that are saved in hep C treatments, and the monies that are saved in, you know, not that I am money oriented, I'm not, but I know that when I talk to people who are, this data is good to have, right? It's morally the right thing to do. It's morally appropriate to give people access to treatments. Most people, when they seek a clinic to go shoot up, they're done with the mystique and allure of using, they're trying to get better. That's their scream or cry for help, that they want to get better. But we don't have enough resources, I think by intent, to get people better. We don't make those resources available. All right. This is This was a study that was done in, I'm going to end this section on these two slides because I think they're really important. This is a study that was done that basically in Canada, I think it was Canada. Was it Canada? Where was it? Yeah, Vancouver. And what they did was, in Vancouver, which was the site of the first safe injection site to open in 1992. And what the police did was, we are going to take a more public health approach toward policing, especially policing individuals that are that we would refer to as junkies or drug addicts or what have you. And with policies that were implemented within the police force, the rates of violence toward individuals went down significantly. And there is a sheriff that's in Massachusetts, right outside of Boston, that actually is making now medical assisted therapy and is creating drug treatment facilities available because they are dealing with such high levels of drug addiction that he's recognizing that the healthcare or the criminal justice system is not the appropriate place. So we are seeing some approaches. We are seeing some moves. They're small, and they need to be very, very rapid now. But we are seeing some movements forward. But this is, for me, this is the most devastating study of all, and speaks greatly to the point that I'm making. And it's complicated, so let me walk you through this. So this is a typical 2x2 table that epidemiologists use. An OST is opioid substitution therapy. So MAT, some people refer to it as MAT, medication assisted therapy, right? It's the use of bupropion or Suboxone or whatever for people who are addicted to opioids. So opioid substitution therapy, and NSP is needle exchange. So in this box, countries that have the highest rates of medication assisted therapy and needle exchanges, right? And needle exchanges right here have the lowest level of IV drug users. Okay, have the lowest level. And these and the circles reflect the highest levels of opioid abuse. And China and USA have the highest levels in the world of opioid abuse. And these are countries that have the lowest levels of medication-assisted therapy, the lowest levels of needle exchange programs, but they have the highest levels of people who inject drugs. So the evidence is clear to me when you look at it on a global level. Countries that put priority in medication-assisted therapy and needle exchanges will have the lowest levels of people who inject drugs. So if you really care about people who inject drugs, we need to be making a priority of these sorts of things to match the rest of the world. Whereas, unfortunately, we are here. This is the USA, this big blue circle right here. Lowest medication-assisted therapy and lowest levels of needle exchanges, highest levels of people who inject drugs. I have 10 minutes, and they wanted me just to speak a couple minutes about some of the work that I do. You're okay with this, right? This is my work outside of medicine, because I have a ton of free time. So my wife wanted me to come up with a mission statement, and she helped me come up with this: advocacy through innovative messaging. So she said, you know, you're always aiming high, right? And so advocacy through innovative messaging. So through this aim, I've really, you know, I started a radio station. I mean, I thought that was kind of cool. But this graph right here just came out a couple weeks ago, and it's probably the most important graph that I can ever show. And what this essentially shows is that as we get more and more people treated with HIV, so their viral loads become undetectable. So as more and more people, as their viral load suppression increases, as they have more and more suppression of their viral load, the incidence of HIV declines. Okay, yeah, that's a big effing deal, okay? And the reason why it's a big effing deal is because it goes to this right here. Undetectable means untransmittable. When you can get people's viral load undetectable, they don't transmit virus to their intimate partners. We've known that for years. But this study from San Francisco was the first, it just came out. Again, this just came out just a month ago. Just came out. Higher the level of viral suppression in a community, the lower the level of HIV transmission. So what is that incumbent upon? So there's 4 things that they did to make that happen. I'm going to save the one that I care about for last. So number 1, PrEP. They increased the number of PrEP medications to prevent HIV, right? So they prevented HIV. Another thing is this concept of test and treat. Test and treat is this idea of when somebody gets diagnosed with HIV, they get started on medications that day. Gone are the days of waiting months, waiting till they have AIDS, waiting to have complications. Those days long, long, long gone. Somebody has HIV, they're diagnosed, boom, you start treatment. I start treatment the day I go around the city, I drive, I skateboard, whatever I need to do to get to wherever I need to go, and I'll start the medication myself with people. I give them the diagnosis and I start them on the medication. I keep medications in the in our clinic, much to the chagrin of people who care about that sort of stuff, and they're trying to get laws passed and changed so that we can just give people medications. I can go and tell you all the reasons why it works. Just trust me that it does. Then lastly, not lastly, but thirdly, increased case management. They increased case management. Why did they increase case management? For those of you that are case managers, I love all of y'all, right? You guys do really the most amazing work. I just go in, I'm there 20 minutes, half hour, blah, blah, blah. We sit and we joke, blah, blah, blah. Like, I educate, blah, blah, right? You guys are the ones that are actually doing the heavy lifting, right? Because the system of healthcare that we have is not any good. It's archaic, and it's purposely meant to keep people out of the system. Case managers are people who actually bring people into the system, keep them in the system, and then advocate for them as they move through the system forward, right? So they increased case managers. Lastly, the thing that's important for me is they increased HIV testing. Because the only way that you're going to get to getting viral load suppression is that you got to find out who's positive so that you can suppress the viral load. So when you look at the U.S. care continuum, you could see that our viral load suppression has a lot of work to do. This is a much more generous number than I would give, but I will still give it. If they say 60% of us are virally suppressed, I think it's less than that, but that's the number they give. This is a slide of all the states. The reason why I'm showing you this slide is that there was an animation, but I took out the animation with this slide, is that what this is basically showing is that 1 in 5 people living in Louisiana don't know they have HIV. 1 in 4 to 1 in 5, right? So 20 to 25% of people living with HIV don't know they have HIV. The rest of the country, it's 1 in 10, 1 in 15, right? For us, it's 1 in 4, 1 in 5. Especially in New Orleans, 1 in 4 in New Orleans, right? So 25% of people living with HIV don't know they have HIV. What are they at risk for doing? Transmitting. So those are the folks that we need to get to if we really are trying to get to an HIV-free generation. Oh, it did. So this is the Time Magazine quote in which they quoted me here saying, testing, 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 single-handedly the most important thing we can do to reduce infections. Here, Time Magazine came up with 77% as the number as compared to 1 in 8 for the rest of the country. So again, advocacy through innovative messaging. So what did I do? So the first thing I did is after Katrina, Robert Fogarty was a world-class photographer, moved to New Orleans, and he had people write messages on their arms. Initially, it was HIV message. It was post-Katrina type messaging. It was a way for people to communicate to their families that were around the country, right? Then he broadened it and then had me come in and do a Dear World. If you guys have ever seen the Dear World now, he's all over the world. He's doing this all over the world in some of the most remote places in the world. And so he reeled me in the 2009, 2010, and had me cut this ad for him that he gets used to, which is get tested for HIV. This is obviously an older way that we test, which is a swab. We don't use that anymore. But then I developed this thing called HAMP, the HIV Awareness Music Project. We're in our 10th year now, in which we do is I get musicians and we just test on stage. So I get musicians, I'm a musician, you'll see that in a second, and we get, sorry, I am a musician. We get musicians to come on stage, and I mean, look at that jacket. Who wears a jacket like that? It's got to be a musician, right? I mean, So and we test live, and we kind of I'll test anything. They wrote a puppet show for me, so they had me go up on stage and test one of the puppets. So they brought this is not children puppet shows. These are adult themed puppet shows. But you can see me testing. He's like, I need Dr. Dery to come here and test me. And I jumped up on stage and I tested the puppet, right? And they played a ham show. So again, it's important for us to find these people because the viral load is important. 1 in 5 people don't know they have HIV. They're accountable for 60 to 80% of new viral transmission. So it's important for us to do that. And so I took this whole concept of HAMP. Again, we're in our 10th year in New Orleans. I had the opportunity to take it out to Uganda. So I brought a bunch of different musicians with me. And in our 2nd year, we got 10,000 people to show up. And of those 10,000 people, we got 25% of them to get tested for HIV. And right now, we're still doing this. I had to step away from the project to focus on other things, but they are now doing usually 3 or 4 a year now in very remote areas, and we bring out Ugandan and Rwandan hip-hop artists that otherwise people have only seen on their phones, would never have an opportunity to see live, and provide them. We say to them, we're going to pay you for your work. So the work that you're doing is you're allowing yourself to be HIV tested. We're going to pay you back by giving you something you're going to want to see, which is in this case a music artist. I have a phone call coming up in an hour with United Healthcare to try to do something like this, but for flu vaccines this year, and we're calling it VAMP, Vaccine Awareness Music Project, and I just really love the name. But we're doing this, the same concept, is get people, especially after the big debacle with the flu vaccine or the flu that was last year. But this was kind of my big pride and joy, was being at the right place at the right time to start a radio station. My wife is like, you're not taking on a new project. I'm like, babe, please. Like, I'm going to call it WHIV, Programming Dedicated to Human Rights and Social Justice. The FCC will never go with it, right? Wrong. It was like, I've got good news and bad news. Good news is that I started a radio station. Bad news is, I started a radio station. I had no idea. Like, some people would even argue that I still have no idea how to run a radio station. But we're 4 years in. We started on World AIDS Day 4 years ago, which was on December 1st. And we're going really strong. And we get press regularly about the work that we do. And this was St. Charles Avenue Magazine is like the big uppity, I'm sure you guys have your own version of St. Charles Magazine here. It's the magazine that's, the monthly that goes out to like the socialites, right, of North. St. Charles Avenue Magazine is the socialite magazine, right? So the people that are usually in the magazine are not anybody that looks like me or thinks like me or anything like that. So I get a phone call from St. Charles Avenue Magazine, right? And they're like, yeah, and can we speak to Dr. Dery? I'm like, yeah. They're like, St. Charles Avenue Magazine. I'm like, really? They're like, we want to do an interview with WHIV. I'm like, what? Like St. Charles Avenue Magazine? I'm like, are you sure? I'm like, that we're an activist radio station. And she's like, and I quote, Dr. Dery, even the uptowners hate Trump too. So there's my badass wife, and we started the station together. And I'm just showing you the faces of what WHIV looks like now. We have this live remote now that we do with the prominently black station called WBOK, WHIV. They take an hour. There's my co-host Kenny Francis. We do this live once a month at the Ace Hotel, but we remote weekly with them. This is one of the local politicians who's been very strongly trying to oppose short-term rentals in New Orleans. But again, I'm just taking you through faces and people through that are our hosts and DJs. Gina Brown is one of the largest hip-hop artists in New Orleans. Judge Calvin Johnson was the first black judge to have a federal position in the state of Louisiana. Some of our other luminaries here. We have shows that are dedicated to the LGBT community. We have several transgendered hosts. We have a show called Islam in the Crescent City with Jenny Yanez, and you've made it in the world when you've been trolled by David Duke. So that was one of our biggest, like, well, if we're pissing off David Duke, we've got to be. So he went after Jenny Yanez, and Jenny's totally cool with me showing this, and she supports me lecturing on the slides, I want you to know. But she's like, he's not going to scare me. I'm going to do what I want to do. So again, just wanting to show that we have a very diverse group. I'm very proud of our diversity of all the live shows that happen. These guys are the workers' voice. When I get into this group right here, like, it's so funny how, you know, like most circles I walk through, like I am the most leftist, progressive person until I get into this group and they think I'm the man. Right? That's how way to the left those guys are of me. But their voice is very important. I think that we need to have them on air. And so this is the New Orleans Abortion Fund. This is a nonprofit organization, and they go on air, and they bring women on air, and they talk about abortion stories, because how do you normalize abortion? You say the word abortion regularly, and then you talk about your abortion stories. And that's how you normalize abortions, and that's how you bring reproductive rights and reproductive freedom to women. I also make music to promote social justice, and that's I'll just kind of I think that's it. So I'm in half a dozen recording bands in New Orleans because I have a ton of time, and a lot of the music that we make and then we're committed to is music that's dedicated to social justice, because in the end that's all I have left to give. Like, I try to change that system, and I will continue to try to change everything that I've kind of talked to you guys about, and I try to make a difference. And right now my making a difference is going around the country giving lectures like this and trying to advocate very hard to undo racism in medicine. I think I had one more picture here. Oh yeah, we made a movie too, but that's different. But I wanted to end on this slide. My patient walked in and he's like, "You haven't looked at me yet." And I'm like, "What are you talking about?" He's like, "You haven't looked at me yet." I'm like, "Yes, I've looked at you." And I'm on the computer. For those of you who go to your doctors, and for those of you who remember the days before computers were in doctors' offices, you remember that your doctor used to look at you. Now your doctor is constantly on their computer, right? And so he's like, "If you looked at me, you would see what I'm wearing." And I looked up, and I was like instantly embarrassed and happy at the same time. I was embarrassed because he's right. I had not looked at him, and I missed this amazing shirt that he was wearing. And he says, I wore this shirt for you. And so what I really want to end is that racism is the single most critical barrier to building effective coalitions for social change. Racism has been consciously and systematically erected, and I hope that I showed that in this lecture. And it can only be undone if people understand what it is, where it comes from, how it functions, and why it perpetuates. So anyway, I'm just a few minutes over, so thank you guys so much for giving me the opportunity to be here.